All right, so here's the first ARS question. Bladder cancer is a good target for immunotherapy based on the fact that you can instill drugs directly into the bladder. It has a high rate of somatic mutations, low numbers of T cells in bladder tumors, gives it a better immune response, and systemic immunization with BCG can clear superficial bladder cancer. So very good. Yeah, the correct answer is number 2, the high rate of somatic mutations. Next, ARS. Which of the following statements is true concerning checkpoint inhibition and bladder cancer? BCG has been shown to work through the PD-1, PD-L1 checkpoint inhibition. Checkpoint inhibitors are approved for both systemic and intravesical use. All newly approved checkpoint inhibitors block both PD-1 and PD-L1. And the FDA has approved a complementary diagnostic, the PD-L1 SP142 assay with atezolizumab. Wow, good group, good group. You got a smart group here, Dr. Crawford. So basic concepts in bladder cancer. Immunotherapy is the hot topic. As everyone knows, we're in sort of a golden era for almost every malignancy concerning immunotherapy. There's so much that we've learned over the last 25 or 30 years how to take our own innate immunity. And everything that we're talking about is tweaking our own immune system. The only one that maybe is a little bit different is the CAR-T therapy, but everything else is just an enhancement or an augmentation to our existing immunity. So, of course, BCG is the big dog when it comes to immunotherapy of almost every cancer. It's the model. It was one of the original ones that's out there where you're stimulating your own immune system to reject the cancer. The interesting thing is BCG has also been used for melanoma, and directly injecting BCG into melanoma has caused many remissions. But BCG immunotherapy, everybody knows, is our standard of care. It can reduce recurrence, progression. It has to be given at least 1 year and probably up to 3 months for high-risk non-muscle invasive bladder cancer. And overall, it is superior to intravesical chemotherapy. So we set the stage for talking about basic concepts in immunotherapy, knowing that we as urologists who have been using BCG extensively since the late 1980s and early 1990s surely should be the thought leaders in a lot of this area of immunotherapy. So the mechanism, although we've been using it for a long time, is really still unclear, but it is clearly recognized as an augmentation to our own immune system. And we did actually some work in the early 1990s. Actually were the first ones to show that BCG, one of the reasons that it does stimulate the immune system, it's actually taken up since the gag layer is absent on urothelial cancer. BCG is actually engulfed by the bladder tumor itself, and that is one of the ways that the immune system is stimulated. Again, safety, it's a pretty safe approach, and we recognize if it's used properly, it is a good immunotherapy. So what I want to do with that background of recognizing the fact that as urologists, we are the leaders in immunotherapy, let's roll things back now and talk about kind of the basics of immunology and exactly why things like BCG work. So Dr. Weinberg has really been famous for putting these, all these hallmarks of cancer, what makes cancer develop, what makes cancer progress. But one of the big things that Dr. Weinberg has really shown us is the fact that the immune system has a major role not only in clearing cancer, but allowing cancer to progress and develop. So immunocompromised patients, anyone who questions the role of our innate immune system really has to look at some very significant data that's out there to, we don't have to convince ourselves, but it's nice to have the data to back up our concepts. So if you look at historically, those people who are on compromised immune systems, such as renal transplant, liver transplant, and others, you can see that the significant increased risk of cancer in these individuals, suggesting that immunosuppression of your own innate immunity causes or encourages, allows the development of malignancy. So the immune system has now been broken into sort of 3 E components, as they're called: elimination, equilibrium, and escape. And basically, how our body interacts with the tumor falls into one of these three categories. So this is the concept of how our bodies normally will get rid of a tumor, and through elimination. And in fact, it is projected that as we get older, as our immune surveillance declines and our ability to recognize foreign invaders, be it pneumonia, be it herpes zoster, whatever it might be, the reason that older folks get more cancer is because there's decreased immune surveillance. So what happens is that a tumor can be cleared and eliminated by our own intrinsic immune system. Most of us are probably harboring immune cells most of the time, and they just sort of sit in an equilibrium. They don't get an upper foot, they don't grow. If you look at our good old friend renal cell carcinoma, the old famous 1 to 2% spontaneous remission, it probably had to do with the elimination of the tumor by our intrinsic immune system. But escape is what we're talking about, and escape is when we have things like the checkpoints that get breached by the tumor and allow the tumor to grow. So this concept of escape, equilibrium, and elimination has been shown to be operational in most tumors. So anti-tumor or anti-cancer immunotherapy is mediated through multiple steps. There's not one it's not a single bullet theory here. There's many different phases. So antigens being released by the cancer cells, antigens get presented to T cells, the T cells get primed, they traffic to the tumor, they infiltrate into the tumor, they recognize the tumor, and then they bring in other cells to go ahead, CD8 and CD4 positive cells to go ahead and clear the tumor. So tumor immunology is almost completely dependent. Our intrinsic immune system is totally dependent on the activation of our T cells. Bare antigens floating around in the bloodstream tend not to be recognized as foreign. So the tumors, which might be shedding DNA out into the systemic circulation or other cell surface markers, are not going to be recognized unless they get trapped by a T cell and then presented to a macrophage and tell the macrophage, look for this guy, it's a bad actor, and go ahead and kill it. So we have a lot of players on the field when it comes to our immune system. You have things that activate the immune system, but you also have to have things that slow the immune system down, because if the immune system goes wild, you develop autoimmune diseases, and you can actually create a lot of problems. And that's one of the things we're recognizing now with a lot of the things such as the checkpoint inhibitors. There's coming in a whole new class of side effects that we're only now beginning to recognize and figure out how to overcome. But activating and inhibitory factors in this immune response, and I want to focus on the inhibitory ones at the bottom, the CTLA4, the PD-1, the PD-L1. Basically, these are the main ones that we are now manipulating in the immune system to treat diseases such as bladder cancer. We're taking the brakes off the immune system by slowing these inhibitory factors down and allowing our own immune system to go ahead and clear the tumor. So basic principles of cancer immunotherapy. The immune response to cancer, as we mentioned, has stimulatory and inhibitory. What we want to do to treat these cancers, get rid of mostly the immune inhibitory factors. Stimulatory factors, things like IL-2 that we're all familiar with, and other interferons we've used for years, but the big magic ticket that's really happened is understanding how do we take the inhibitory factors and negate them, slow them down to allow our own immune system to take over. So the big checkpoint inhibitors, the CTLA4, the PD-1, the PD-L1, the ipilimumab is that CTLA4, which has a big play right now in melanoma, and in combination with tumors such as bladder cancer, combining checkpoint inhibitors is going to be the next wave, as was addressed earlier, has been some of the earlier talks. So the checkpoint inhibitors block the immune checkpoint to enhance the T cell's ability to identify and eliminate tumors. So when you look at immunotherapy, we have two general classes: passive immunotherapy and active immunotherapy. For urologic tumors, passive immunotherapy doesn't do us a lot of good, because for passive immunotherapy, you have to continually administer these medications. And as the tumors grow, you can't really keep up with the growth of the tumor and really try to clear it. But there are monoclonal antibodies out there for other diseases which are effective. However, for things like bladder cancer and kidney cancer, they tend not to be as effective. However, active immunotherapy, where we kick our own T cells into high performance to identify tumors, is really some of the most effective approaches that we have. So remember that antigens on the tumor cell need to be presented to T cells and antigen-presenting cells. So and I might have said that backwards a minute ago. The macrophages eat up these tumors. They then process the antigens, stick them outside, and tell the T cells, please seek these tumors out and destroy them. So that's this antigen presentation concept. Dendritic cells, of course, dendrion, that name sounds kind of familiar, is a way of taking antigen-presenting cells, putting them back in the body, and it's those APCs in dendrion's Provenge, for example. You put it back into the patient, those dendritic cells identify prostate cells. By identifying those cells, they then tell the T cells, go after this particular tumor. So when you look at specific immunotherapies, they come into these categories: vaccine-based, cytokines, monoclonal antibodies, checkpoint inhibitors, and CAR T cells or chimeric antigen receptors. The vaccine-based therapy, basically, we kind of put Sipuleucel T and BCG into that bucket because we use the term vaccine, but essentially what you're doing is you're identifying the tumor by injecting more of the tumor factor in the patients, so that results in the T cells finding those tumors out and being killed. Cytokines are things like IL-2 and interferon. The problem is they're kind of transient in their effect. Yes, they can clear some tumors, but we know that IL-2, if it clears your tumor, and that's the only thing that's been found at this point to ever eradicate renal cell carcinoma, it can be effective, but these things tend to need to be chronically administered. Monoclonal antibodies. There are monoclonal antibodies that block growth factors. And again, there are certain tumors that are exquisitely responsive to things like bevacizumab targeting VEGF. But when it comes to urothelial and other malignancies, we haven't been very effective. We have some monoclonal antibodies directed against growth factors for renal cell carcinoma, but they have not been that effective in bladder cancer. Checkpoint inhibitors are technically also monoclonal antibodies, but they are different in that they are blocking the immune response and basically taking the brakes off the immune system when the tumor is trying to suppress your immune system. These monoclonal antibodies go in and block either the PD-1 or the PD-L1 receptor and take the brakes off that interaction, because these tumor cells are trying to suppress the immune response. And this has been the big breakthrough over the last 5 to 7 years, identifying the PD-1 and the PD-L1 factors on both the tumor and the T cells. So these are monoclonal antibodies that block the PD-1 or the PD-L1 that we'll talk a little bit more about in a minute. Lastly, hot thing in the world right now is the CAR T cell, where you're genetically engineering patients' T cells to reintroduce genetic material into a patient's own T cell to go after, primarily at this point, it's being looked at mostly in hematologic malignancies, but there's a lot of work being done in solid tumors right now, and we'll have to see what direction that goes in. So this is kind of a little bit of a review before we get into the real nuts of the nuts and bolts of the PD-1 and the PD-L1. So you can see that the BCG can either be taken up by the tumor cell and then recognized as a foreign invader, or it can cause direct inflammation in the bladder. Because remember, GAG, the glycosaminoglycan, which is normally protective of the bladder, is not on tumor cells. So what happens is these tumor cells are sitting out in the bladder with no protective cloak upon them, which is the GAG layer. So what many happens is they actually take up the BCG and then get identified as foreign invaders. And again, the BCG itself sets up cell-mediated immunotherapy, which also results in some of the side effects. But the big thing right here when we talk about immunotherapy is the PD-1 and the PD-L1 immune checkpoint inhibitors. And right now, these are the ones that we have. And we have people in the audience like Dan Petrolak who are real experts in this area and done some of the pioneering work. But we now have 5 different immune checkpoint inhibitors that are available to us in bladder cancer. All of them are either in primary, and none of them are for localized disease, although as we'll talk a little bit about, there are a bunch of trials out there looking at these immune checkpoint inhibitors in localized disease. So here's really probably the take-home message of the whole talk, looking at anti-PD-1 and anti-PD-L1 activity. So you can see what happens on the T cell, the PD-1 and the PD-L1 interact. So PD-1 is on the T cell, PD-L1 is on the tumor cell, and what happens is when that T cell receptor identifies the tumor cell, it tries to suppress that response. And if you can block that you either block the tumor ligand or you block the T cell receptor, in order to take the brakes off the immune system, because this tumor cell is trying to suppress this anti-tumor effect. And by blocking it either on the ligand side or on the receptor side, it allows that to take the brake off the immune system and allows that T cell to adequately identify that tumor cell and cause it to undergo apoptosis. So why is bladder cancer a good target for immunotherapy? You guys did a very good job with this. Bladder cancer has almost as much somatic tumor mutations as things like melanoma and lung cancer, which tends to be the the ones that, if you look at the responsiveness for these immunotherapies, they tend to be the ones with a lot of somatic mutations, meaning that they look so wild on their cell surface markers, it's a heck of a lot easier for your immune system to recognize them. These high rates of somatic mutations, we believe, may make the immune response and the immune treatment work much better. And the urothelial cancers express these substances that suppress the immune system, and such as the PD-L1 ligand. So CD4 and CD8 T cells express inhibitory PD-1 to prevent overstimulation of the immune system. So your body's trying to modulate this. Your tumor is trying to suppress it. Your body's trying to turn it on. And by going in favor of your body, by blocking the immunosuppressive activity of PD-1 or PD-L1 interaction, that is how we hopefully are doing better with clearing these tumors. So immune cells within the tumor predicts overall response. The more CD8 positive cells you have in muscle-invasive bladder cancer, the better the patients do overall from a survival standpoint. Checkpoint inhibitors and biomarkers, Dan will, I'm sure, comment a little more about this. It's not clear that the markers are completely reliable when it comes to identifying PD-1 or PD-L1, because many patients, in spite of having negative PD-1 or PD-L1 staining, still respond to some of our checkpoint inhibitors. There's a lot of PD-L1 and PD-1 monoclonal antibodies out there. So while a lot of this is a research standpoint and companion assays are approved, they're still not as predictive for response as we would like them to be. So if you look at bladder tumors and you look at the PD-1 and the PD-L1 expression, again, you can see that they overexpress. This is from a gene standpoint, not from an immunohistochemical standpoint. This is from a research standpoint. But in fact, and I'll see what Dan thinks about this, this may actually work its way in and be a more reliable marker for the PD-1 and the PD-L1 inhibitors. Here's just an example of the Ventana SP142 assay that looks for PD-L1 immunohistochemical staining, both on the tumor itself and on the tumor infiltrating cells. Lastly, intravesical immunotherapies. We have a whole bunch out there. Most of these right now live in the world of superficial bladder cancer. The one, and again, that's been spoken about is the Instellodrin, and I think this is the one that's going to be our closest next immunotherapy specifically approved for intravesical use is probably going to be this recombinant adenovirus interferon vector that was addressed earlier, and we think this will be the next one specifically approved as an immunotherapy in superficial bladder cancer. Whole bunch of studies out there, dozens upon dozens of studies looking at these things systemically for early disease. So this is going to be the next thing urologists are going to have to be aware of with these systemic therapies going for superficial disease. Again, where are we today? These are the bladder checkpoint inhibitors. They're either directed at the PD-L1, either at the ligand or the PD-1 receptor. And again, we sort of have an embarrassment of riches right now. We have a lot of these agents out there, and I think you develop familiarity with one of these agents and decide which one that you're most comfortable using. So I think that hits the end of the talk. So quick overview. This is hundreds and hundreds and thousands of investigators sorting through all this immune stuff that we can summarize in a few minutes. But again, clearly, I want to go back to what we said originally. Urologists, I think, are the leaders in immunotherapy. Dan, correct me if I'm wrong, having used BCG as one of the primary immune treatments since really it was FDA approved in around 1990 or 1991. So we do have a lot of experience. However, just remember, once we as urologists start to move over into systemic therapies, it's a whole new ballgame. We're identifying many, many, many more autoimmune diseases. Hypophysitis, is that the proper term, Dan, where you blow your pituitary? Really bad side effects for patients treated with these PD-1 and PD-L1 inhibitors with kidney cancer, having a lot of pulmonary toxicity. Many of it is fatal. So I think we have to be a little cautious as a group as urologists start to get into systemic treatment with these immune agents. It's really opening a Pandora's box, and we need to learn a lot more about them going forward. So thank you.